Hello, bonjour, and welcome to this public webinar offered as part of Healthcare Excellence Canada's program, Sparking Change in the Appropriate Use of Antipsychotics. The program aims to support long-term care homes across Canada to improve the appropriate use of antipsychotics through person-centered care. Registration is still open, but is closing soon on October 1st. So if you are a long-term care home in Canada, you're welcome to join us for further quality improvement supports, coaching, and the final financial award opportunities. So my name is Nicole Pollock. I'm a Senior Program Lead on the Health Innovation Programs team here at Healthcare Excellence Canada. My pronouns are she, her, and I'll be your host for today's webinar. We are pleased to offer French simultaneous interpretation. So if you wish to hear the voice of the interpreter, please select French from the interpretation menu at the bottom of your screen. We invite you to share your questions and comments at any point during the webinar in English or French by typing into the chat box. We will address as many of your questions as possible during the Q&A session near the end of the webinar. If you need support at any time, please reach out to our tech support using the chat feature. This session is being recorded, and the recording will be made available in the coming days through our YouTube channel, which will be linked in the chat, and will also be posted on our website within a few business days. So I want to start by acknowledging that I'm joining you from Anishinaabe, the traditional territories of the Anishinaabe people, colonially known as Ottawa. Healthcare Excellence Canada's offices are also located in Ottawa, but with staff all across the country. HEC honors the traditional territories upon which our staff and partners live, and I'm grateful that HEC supports our journey towards truth and reconciliation. I invite you to share who you are and where you're joining from in the chat box. So for those of you new to us, HEC is a not-for-profit organization funded by Health Canada. We collaborate with diverse organizations across the country to spread innovations, build capability, and catalyze policy changes that improve healthcare safety and quality. I'd also like to thank our supporting organizations who continue to help promote the program with ongoing recruitment of homes to participate and to review the award submissions that we receive. So speaking of awards, we want to celebrate the latest winners of our Progress Award. Each of these long-term care homes listed won $5,000 for their progress towards improving the appropriate use of antipsychotics in their home. They shared with us how they've been using person-centered care to help residents and how they've discontinued or reduced the use of antipsychotics where they may no longer be helping the resident. So a huge congratulations to these homes, and we look forward to seeing all of the participating teams' continued progress. Again, if you would like to join the Sparking Change in AUA program for the chance to win financial awards like this one, you can still register through the QR code on the screen or through our website. But again, registration closes October 1st, so no time like the present. Be sure to sign up right away. So we're gathered here today to talk about the long-term success tool developed by HEC, also to discuss how to plan for sustainability. And then we'll hear a success story of the long-term gains sustained at the Rexton Lyons Nursing Home. And finally, we'll save some time for Q&A. So lastly, I'm pleased to introduce our speakers for today. We're joined here by the lovely Julie Weir. She has over 20 years of nursing experience and holds both a bachelor's and a master's of nursing from the University of New Brunswick, where she also has served as a professor. She's worked in both the acute and long-term care sectors with significant time spent working at the provincial level with the New Brunswick Association of Nursing Homes. During this time, Julie led the provincial scale of several quality improvement initiatives. Julie currently serves as the president-elect to the board of directors with IPAC Canada, as well as the clinical director operations, patient flow, and ambulatory care with Horizon Health. So in addition to working with HEC as a coach for several initiatives, she's one of the long-term care co-leads with Choosing Wisely Canada. And a very warm welcome to Sharon and Juanita from Rexton Lyons Nursing Home. Sharon McDonald, an RN who's devoted more than 40 years of her career to the Rexton Lyons Nursing Home, currently in the role as Director of Care. Known for her deep passion for residents and her unwavering commitment to their well-being, Sharon has been a guiding force in creating a caring and supportive environment. She believes not only in ensuring the highest standard of care for residents, but also that of quality of life. Equally important to her is ensuring that staff are provided with whatever support they need. Beyond her professional life, Sharon is a devoted wife, loving mother, and proud grandmother, finding joy and inspiration in her family. And Juanita Bear has also dedicated over 40 years of her career to the Rexton Lions Nursing Home, where she has been a steadfast advocate for resident-focused care. Her leadership extended beyond her workplace as she served as the president of the New Brunswick Activity Directors Association for 5 years, helping to shape programs and support for seniors across the province. Known for her passion, commitment, and heart for enhancing the quality of life for residents, Juanita contributes to a lasting impact on her community. And beyond her professional achievements, Juanita is a wife, mother of 2, and a grandmother to 2 of the sweetest grandbabies. So once again, feel free to drop any questions into the chat box throughout the presentation. And without further ado, over to you, Julie.
Thank you so much, Nicole. And I am privileged to be here on this webinar today with 2 very passionate people who work in long-term care in my province of New Brunswick. So very happy for you all to learn more about the great work happening at their home. But before we get there, let's talk about a tool that can help. So today we're going to talk about sustaining the gains. So the long-term success tool is a tool that has been created with the support of a researcher many years ago who was doing a lot of work around looking at sustainability of quality improvement initiatives in healthcare. And what we have all experienced over our years in healthcare and what she was able to identify through the literature is that the sustainability of especially healthcare related QI is very low, like embarrassingly low. So she did work in her PhD to figure out a way to support healthcare to be able to sustain their gains. And so she worked with HEC to help create what we now call the long-term success tool, or the LTST, because we have to have an acronym for everything. So this is a way to identify risks and strengths that cover a list of 12 factors that are known to impact the long-term success of an improvement initiative. And the content for this tool is reproduced and adapted from Laura Lennox. She was the researcher at the time, and she was with Imperial College in London, and she had a really cool accent, and she's a really nice person. So there you go. Next slide, please. So the long-term success tool covers these 12 items. So those include commitment to improvement, involvement, skills and capabilities, leadership, team functioning, resources being in place, progress monitored, evidence of benefits, robust and adaptable processes, alignment with culture and priorities, support for improvement, and alignment with environment. So now when you think about sustainability of good improvements, positive movement through quality improvement, and you look at these list of factors, doesn't it make sense that these are the most important factors in determining or promoting sustainability of good changes being made through quality improvement? Because remember, if we never change what we're doing, we're never going to improve. And I want you to think about that for a moment. Change can be hard, but without change, we're never going to improve. And I'm sorry, I don't want to work in a sector that never has change. I get excited by change. Sometimes the change itself scares me to death, but I get excited for change because that is how we improve. And I don't want to be stagnant in my healthcare career. I want to see improvement over time. Next slide, please. So here comes the content. So I will go through each of the 12 items, the 12 important items to determine or support sustainability. But I want you to think as I'm reading through this content, I want you to think about how you think your team in your home or in your team, your teammates would score on these items. Okay, so I'm giving you a little bit of homework, right? So the number one is commitment to the improvement. The item that goes along with that, the quote is, "My team understands what the improvement initiative is trying to achieve and believe this work will lead to improved processes and outcomes." So if we're talking about the AUA work, does your team understand that you're trying to decrease or deprescribe potentially inappropriate antipsychotics? Or do they think you're just trying to remove all the drugs, right? Do they truly understand the goal of your improvement initiative? And we've added some reflection questions. Do you feel committed to the initiative and understand what the initiative is trying to achieve? Remember, it's not just about the numbers, right? This is about improved care. Do you believe the initiative will improve processes and outcomes? Or is it just another checkbox that we're checking? Do you think there is commitment across the team as a whole, or is it just that core team? Are they the only ones who are committed to it? And has a shared aim been established for your initiative? So we set those in the initial challenge, right? An aim is important. An aim is important for your team members and for your entire team to understand what you're really working towards. Next slide, please. Number 2A is involvement. I have the opportunity to provide input into the improvement initiative, and I feel a sense of ownership towards the work. I am able to express my ideas freely, and they are openly considered by the team. So this is where our huddles really comes in, isn't it? Do you have an opportunity for the housekeeping staff or the environmental staff to have a voice? Or the dietary staff? Or is this work only just being guided by the nursing staff? And the reflection questions include, do you personally feel involved in the initiative? So if I'm filling out the long-term success tool, these are the questions I'm asking myself. And am I given the opportunity to express my ideas and recommendations, recommended changes to the initiative when necessary? So this is really important in terms of the huddles. Next slide. 2B is also involvement, but it's from a different lens. So there's a wide breadth of involvement from people, including patients and members of the public who regularly feed into the improvement initiative. So do your family and resident councils have a say, have an opinion about the work that's happening? Are they even aware? So my reflection questions as I'm filling this out, do I think the initiative has involved the right people? If not, how can this improve? Who can I bring that message to? Does your initiative involve patients affected by the improvement? Is there involvement from staff who will be delivering the improvement as part of their day-to-day practice? So again, looking at, we're all part of the care team, not just one group. And does the team have a good spread of views, skills, and expertise? Are there groups of people you still need to involve? And who are you going to tell about that? Next slide, please. Number 3 is skills and capabilities. Staff have the necessary skills to deliver the improvement. Training and development opportunities are available to staff, volunteers, and other people involved. So here is where we talk about the importance of providing support to your teams to make sure that they understand not only the aim, not only what we're trying to gain through this work, what our outcomes are, but also the steps to get us there. So that's why we've posted the videos for you to use as appropriate on within your team. There are modules that you can watch, just the individual module about the medications, or just the individual module about the huddles, or they can watch it all. So the reflection questions that I will think of as I'm going through and answering as a team member on this team: do I feel able to fulfill my role within the initiative? Do you or staff involved require further training or education to deliver the improvement effectively? What should be done to address these needs? Where can you get that education? Our modules are just one opportunity, but you have GPA training, you have PIECES training, you have You First training, all great person-centered approaches to care. And our new staff informed about the initiative and their role in it. Here's that sustainability piece, isn't it? Have you adapted your processes to support sustainability of this AUA work? Is this part of your orientation to your organization? And do you have policies to have that ongoing education? Because, I mean, listen, I've been in healthcare for a long time, but every time I go through, no matter what, if it's CPR, if it's ACLS, I learn something new every time. So we have to understand that about adult learners. I'm not going to absorb all the education the first time. So what, as an organization, are you going to do to help support the sustainability of this great work? Next slide, please. So leadership. Now you're talking my language, right? My improvement initiative has supportive and respected leaders and/or champions who advocate for the improvement, communicate the vision, and effectively manage the process. So as I'm filling out my assessment, are leaders actively involved in the initiative and able to garner support and enthusiasm for the work? So as a leader, you don't need to be involved in every meeting, but your staff need to feel like you're engaged. They have to understand whether it's, a quick walk through the unit, how are things going today, or stepping into a huddle to, offer that leadership, that high level oversight and be supportive of your team. It is important. Even though some people think, oh, me stopping in a huddle for 10 minutes, that doesn't really matter. I'm here to tell you it matters. And your frontline staff will tell you it matters. Are leaders available to help solve problems? There are some barriers that only the leadership can remove or slide to the side so that we can work around different challenges. And how do you think leadership could be strengthened? So there's always opportunities for leadership to be strengthened, right? But one of the ways that leadership can be strengthened is through seeing your involvement in what really matters as an organization. And I mean, Sharon and Juanita are going to share a perfect example of how their strong leadership has made such a difference in their home. But, I'm pretty proud of the work they've been doing. Next slide, please. Step 5 is team functioning. My team is working well together. There are clear responsibilities and the work is shared amongst the group or amongst the team and does not rely on any particular individuals. That can be a challenge, right? When you have the champion, again, going back to the leadership slide, the champion who is championing this work can't be the only person doing that work. The champion needs a vacation too, and sometimes the champion gets sick, but they need to have followers who are able to step up and step into place. So I recently, when I was doing some teaching at UMB, taught a course on leadership in nursing. And I really love this analogy when they were talking about leadership is kind of oftentimes functions as a, so geese, when they fly, the Canadian geese, when they come in the spring and leave in the fall, they fly in a V formation, and the leader is out in front, and the leader is, taking on the majority of the wind. They're, whatever is coming their way, they're kind of there to dodge and dip and turn different ways. And sometimes that leader gets tired, and that leader doesn't send an email to the rest of the geese in the back of the line. That leader just falls back, and somebody else slides into that spot. So it's just an inherent thing that they do. And I didn't know this about them, but it says a lot about leadership. As a leader, you have to have followers who can fall in line when you need a break. And it doesn't necessarily come by way of an email asking you if in 2 weeks you can step up. It actually happens in real time. So the reflection questions around the team functioning: how well do you feel your team is working together? Does the team meet and communicate on a regular basis? Again, think about your huddles. Have clear roles and responsibilities for team members been established? And in your opinion, are team members fulfilling these roles and responsibilities? Are skills and expertise of the team members considered and used? And what do you think can be done to improve team functioning? We know team functioning can make or break things like this, quality improvement. So really helping to support that is important. Next slide, please. So we're halfway there. Are you still with me? 6 is resources in place. The improvement initiative has financial support to achieve long-term success. We have the necessary staff, material, and equipment. I am given enough time to dedicate to the improvement. So this can be a tricky one, right? When we talk about resources and we talk about financial support, that can be a challenge. But what I want to caution you about is that it's not an all or nothing, all right? So understanding that we're all short-staffed, that's our new norm these days. So understanding that, all right, fair enough, we might be short-staffed, so we can't go guns a-blazing and do it all, but what can we do? And can we do some things that actually alleviate some of the stress of the short staffing? So I've told the story before, and I'll tell the story again. When you're able to reduce somebody's Seroquel and they pick up their fork and they're able to participate at mealtime, then you'll understand that we don't always have to be full staffed in order to try anything. But what can we do given the resources that are in place, or where can leadership help put more resources in place if they're able? The reflection questions here: have enough resources and staff and tools been dedicated to support the initiative? What is lacking? Do you believe the financial support provided will allow the initiative goals to become part of normal working practice in the long term? Do staff have enough time to spend on the improvement? And are resources needed discussed by the team on a regular basis? Next slide, please. So number 7, progress monitored. We talk about this in our graphic, don't we? There is a monitoring system in place that allows the team to collect, manage, and regularly review data. Feedback from the improvement initiative is shared with me. So this goes back to data collection, not necessarily data submission, but data collection at the home level. Have measures been to enable continuous monitoring for the initiative been defined by the team? Do you have an Excel spreadsheet that you collect this manually on? Maybe that's your progress monitoring. Do you think the established measures are able to assess, sorry, my contacts are dry, are able to assess the impact of the improvement? And are these measures regularly assessed? How often do you look at them? If the measures show lack of progress, are the causes for this investigated to inform adjustment? And are team members and staff regularly informed about what is working well and what could be better? Next slide, please. We're getting there. Number 8, evidence of benefits. This is the key, everyone. There is evidence of benefits emerging from the improvement initiative that is evidence that this evidence is regularly communicated and visible to staff and patients. You need to share the results with your staff and residents. Does the evidence for your initiative include both the impact on physical and mental well-being of the patients or the residents? Is there evidence that the initiative is producing the desired impact? So remember, going back to the resident stories, once you get that first positive resident story, and your staff will get on board and become champions. And is evidence of the initiative's impact regularly shared with staff? So really that feedback loop. And if evidence shows lack of progress, does the team explore the reasons? Do you do your PDSA? Do you adjust and understand what the challenges are and change your approach? Next slide, please. Number 9. Can we go to the next slide, FA? There we go. Robust and adaptable processes. Again, back to your PDSA. There is an opportunity to adapt the improvement initiative to reflect local needs, setting and emerging evidence. Adaptations are documented and the success and failures of change are reported. So is there regular review of how the initiative is working? This goes back to the foundations of QI work. How well does the initiative fit within current practices? And do staff and team members need to adapt how they implement the improvement in response to challenges or changing care needs? Next slide, please. Number 10, alignment with culture and priorities. The improvement my initiative is trying to achieve is aligned with strategic aims and priorities of the organization we work within, and our work contributes to these aims. Our work is supported by the policies and procedures within the organization. That's a no-brainer. You have to make sure that this work aligns. Are your improvement goals aligned with the organizational priorities? If not, what could improve that alignment? How well is the work of the initiative being integrated into the everyday operation? So this needs to become your new normal. And does the initiative conflict with other changes taking place within the organization? Next slide. Number 11, we're getting there. Support for improvement. There are values and beliefs in my organization that emphasize the need to improve. Staff and management are supportive of improvement initiatives, and continuous improvement is a priority for the organization, staff, and patients. Do you feel continuous improvement is a priority within your organization? Our staff and senior management, sorry, are they receptive? And number 12, alignment with environment. My improvement initiative exists in a supportive economic and political environment. My team is aware of external pressures and incentives that may influence the initiative. So as you're answering these questions, has the team considered the impact of the external environment on the initiative? Is the political support for the improvement or your initiative? Does the initiative help address external political or economic concerns and goals? And are there plans to mitigate risks due to the external environment? Next slide, please. So these factors are, which, as you go through the survey, it lists the factors that are your greatest strengths. So you can look at what are your goals, excuse me, to maximize these strengths over the long term. But it also identifies which factors are your greatest risks threatening the success and how can you minimize these risks. Next slide, please. So with that, the link is in the slides for the, and also in the chat. Thank you, Joanna, for the long-term success tool. The idea is that you would go through that success tool on a regular basis. Some will do it every 6 months, some will do it every year, and you'll be able to see change over time. So if you have any questions about that, I would encourage you to reach out to your coach and or to HEC directly, and we'll work through those challenges with you. So next, we're going to go to the Rexton Lions Nursing Home. So we have a little video here that was created in collaboration with the Choosing Wisely Canada, and it's a longer video, but we're just going to show a short clip just to introduce you to Sharon and Juanita, and then they're going to tell us about their experience.
I'm Sharon McDonald. I'm the Director of Care at the Rexton Lions Nursing Home. The nursing home has been my second home since I was a student nurse in 1983. We're all looking to provide the very best for these residents who call us home. We believe in the person, whatever their diagnosis may be when they become a resident here with us. We want to make sure that whatever those diagnoses are, what is the lowest amount of medication that they need to live their best quality of life. New Brunswick participated in the 2017 initiative, Appropriate Use of Antipsychotics, and we discovered that we were doing quite well. We recognize, though, that quite well, what is the definition of that, and can we take that a step further to do better? We had time to educate the team further, and then we could look at what other things could we do besides medication on even those complex cases. And we're going to put it into one package so the staff is all talking one language as we give care to these residents.
That's great. Thank you so much. Oh. Sorry, my video's on, my video's off. So thank you so much. So now I'm going to turn it over to Sharon and Juanita for them to tell us a little bit about their story at Rexton Lions. Hi, ladies.
Hi to everyone on the call. A little side note on Julie, as she mentioned, we're all from New Brunswick. So my little Julie, I call her an expert in many things, but one of them is the gentle, persuasive approach as we don't know it. It's her way of nudging Rexton Nursing Home, Juanita and I particularly, into doing all these little side projects. So I do thank you, Julie, for pushing us out of our comfort zone, I guess. And so we will share a little more of our story. So Juanita and I, of course, preparing for this day, we just recently celebrated our 50th anniversary here at the nursing home. And that gave us time to reminisce, and every story is about the reminiscing. So Juanita and I, as shared, we've both worked here over 40 years, and a lot of our team actually laugh about that with us. The changes that we've seen, however, from our early days to current, well, they are nothing short of remarkable. And we have been witnesses to when care was more task focused, and as we move through the decades, and particularly from the last 10 years, we've moved from the task to being person-centered care. So today we've been asked to share that story. So we'll go back as far as the New Brunswick initiative that we joined in 2017. And at that time, we had existing processes in place around that medication delivery piece, with the aim of ensuring that residents in our care were on the appropriate medication routine. And then with the invite to join that initiative, that provided the opportunity to evaluate what we were doing and then to build upon that. So what have we gained? Julie coached us a little bit in content for our little storytelling session. So one of the parts was about what we've gained from 2017 onward. So just a few keynotes, there is more focus on residents being the center of any decision-making process, and shouldn't that have always been what it was about? But that has not always been the case. We can look at the culture in our facility and definitely give that a thumbs up as improved. And of course, there's back and forth on that sometimes, but focus on it. We're content with how we've improved, and we believe that regardless of what anyone's role is here in our nursing home, that we are all care providers. So that wide team comes into helping to bring these residents the quality of life that they deserve. There are strengthened family relationships. So often those relationships develop from when families contact us of, not that we can tell families where their loved one is on the wait list, but we often are approached prior to admission. So relationships start there, and that relationship pattern is improved over the years. Those families are our care partners. They're invited to share the history, and then we can take those history bits and weave that into appropriate care planning for residents. There is a much stronger collaboration between our frontline team and our physicians and our pharmacists. And in Julie's presentation, she did talk about the staffing piece. And for sure, in our little bubble here in a very small home in rural New Brunswick, I can say staffing is, we spend a tremendous time on maintaining staffing ratios, and we are so fortunate. And I do believe that because we are in that small little bubble of Rexton, it's not easy. It's a day-to-day, and sometimes we have to do what I call creative staffing of dividing a 12-hour shift into 3 pieces sometimes, but we remain staffed. And when we're participating or actively involved with a resident trying to do deprescribing, that human resource piece of having people that have time to sit with a resident in the snoozling room or use that intervention piece, it is a very important factor. So then we would move to what comes to mind, what is the spark from 2017 onward around the sustainability. So the key points as I was preparing for my little session with you would be that any of the new processes that are considered additional, that if you attach those to what's already existing, it's just, it makes for a seamless transition. And that would be for us, the pre-admission medication reviews. We were always doing those. So now when there's a pre-admission, an extra highlight if a resident is being admitted who is on some type of an antipsychotic, and it just makes the whole process seamless. The thorough history taking, of course, we always did history taking anyway. So to narrow that in, or a sharper lens on that piece. Ongoing medication reviews, always there in the past, building on them in the future, and the resident care conference piece. Ensuring that education includes specifics around antipsychotic usage. So that starts from the time we orientate staff and ongoing. We have been, and I'm very grateful to Healthcare Excellence Canada, we have been successful in being awarded some financial assistance, and that financial assistance has been steered toward, we had a mix of education out there for appropriate dementia care, and we have switched, and there's lots of, as Julie said, the You First and pieces, and we just seem to have a lot of different things going on, and we have focused in on gentle persuasive approach training, and that we started in, through COVID, lots of staff changes, and so much was done on infection control. And we really needed this spring to focus on enhancing all of the team onto a more concrete pathway for education. So that's where our focus is right now, and we're making steady gains. And that piece, we make sure that they understand that if they have come from another home, for example. We have people that join our team and it's like, well, at my other home, they gave whatever Risperdal to a resident because they were wandering, and how come you're not doing that here? So the coaching starts with that really not the right thing for the wandering, and what poor outcomes that can have for a resident. So it is quite a learning curve sometimes. And then interventions, well, so I would not be certainly the fun one in the room today is our Juanita, and she's one of our superstars. So I'll turn that over to Juanita now, because she is my specialist, and the resident story that she will share highlights the strength of what intervention can do in all of our journeys of working within our homes to make sure that we are providing not only quality of care, but that indeed of quality of life.
Hi, everyone. Next slide, please. Okay, a little bit of background. So when this lady came to us, she needed to roam. And she was able to walk around the halls of our building. But as her condition progressed, she required a wheelchair and a chair monitor. So what was happening is she would propel for a while, and then she'd forget that she couldn't walk, and she would be getting out of her chair. And staff would have to, run and put her back in the chair. That's how it kind of started. But as her condition progressed, and she needed to roam a lot faster. So she would propel faster around the nursing home and faster. And this was over a period of time, not days. But I realized at that time she was becoming a danger to herself and a danger to others. Because what she would do is, if something was in her way, she would simply back up a little bit and go forward again. And it didn't matter if that was the edge of a door sticking out or someone's foot, she was going to go over it. So because we had a resident that had this condition prior, I realized that lots of times the only thing we can do is end up medicating them and isolating them to their room, because you can't have people running over other people. So I started to work with this lady, trying to find an intervention that would improve. So in the first picture you see, she is at my desk. She is working with pen and paper, because in her history, I realized she worked in an office. So we're like, okay, distraction. If she has something to do, will she stop the need to roam? Temporarily, not for very long. In the next picture, we actually are music and memory certified. And she is wearing her iPod, and she does love her music. But as you can almost see in the picture, she still needs to move. Next slide, please. Oh, okay, you're gonna play it. You'll see her move her hand because she does enjoy her music, but it didn't stop her from the need to roam around the building. Okay, so continued on. Another day, we tried the iPod, as you can see in the first photo. And a busy mat, which is a sensory mat that has different textures and things she can do, buttons and things like that on it. So she is interacting with that in my office, and it slowed her down, didn't take away the need to move at all. So then I discovered what we call the hug by laugh. So the hug by laugh is a sensory item. I don't like to call it a doll or anything like that, because it isn't. It has weighted limbs that you place around their neck and weighted legs. It's very soft, and inside has a heartbeat you can turn on. So I'm trialing her with that. And as you can see in the photo, she seems to have taken to it quite well. Because I had been working with her for a period of time, I did not want my presence to influence her reaction. So because I want to know if the hug was doing the work or just the company was assisting in that. So next slide. Next slide, please. So as you can see in the photo there, she is actually sitting outside my office with the hug. And I was in my office still observing her off and on just to see how long she was going to stay still. We had never seen her in her wheelchair not moving unless her chair was locked. Her chair is not locked there. The only time we would lock her chair would be at mealtime, so that she could keep moving. She stayed in this position for a period of time until I had to go to lunch. And I asked the housekeeping girls who were there, because I kind of felt bad to take it away from her since she seemed to be at peace with it. I was like, if she throws it on the floor, can you just pick that up and let her continue on? Her chair was not locked. I actually went to lunch, came back, and she was exactly there. I think I ran up the hallway to see Sharon and said, come see this, because it was actually quite amazing to me that she had such a reaction to it. The staff was happy with it. We would give it to her in the morning, and they wouldn't have to chase her chair as much. She was staying seated in her chair, very content with it. So as with all interventions, I wanted to see, so the theory behind interventions is if they had the interventions 30 minutes before the anticipated behavior, would it help in the long, like in her day? So in the little video, if you could play that. Can we start the video, please? The video is the one with her in bed with the hug. So if you're watching close there, I was observing, I was actually doing the recording. So she strokes the hug for a period of time. And then as she folds her hands together, you can almost see her breathe out that sigh of relief. And she is totally calm and totally at peace with it. Her family has bought her own hug. We actually own 2 just for the activity department. So they bought her own. And they have told me that they can now have conversations and visits in her room with her. She has slowed down her need to move around the building so that they're not actually having to chase around to find where she is and follow. They used to just walk beside her as she went around the building. So they can actually sit and visit. Next slide, please. So as you can see, she was able to return to activities in these 2 photos. So here with the ball, she's at Fun and Fitness. She had participated in activities when she first came, but then because I couldn't keep her in the room with us, she would come in and actually wheel right out and not stay. And in the other photo, you see her with the hug, sitting with her husband at music. It would have been music day. And she's actually sitting very content, no rocking, no moving, and holding his hand. So I captured that photo one day and I was like, look at that. What a change for her and them. So it's kind of like a little heart-touching moment for us that we could do that. Her daughter actually said her mother was having actually improved conversations. Not only could she sit and talk with her mom was giving her appropriate answers again. So it took away that anxiety that just busies the mind so bad that they can't even communicate hardly anymore. I did try some things that didn't work. I'll mention, Sharon had mentioned we have a snoozing room. I would take her to the snoozing room thinking that might help. She actually would spin around, open the door and go out. So that part didn't actually work. So I guess our key points is, try your interventions. Busy work can be anything if you know the person, can be folding laundry, handling baby clothes, anything like that. Just keep trying and you might hit on something that really helps the resident and improves their quality of life. And we have another slide. Next slide, please. And I'll let Sharon take this one.
And I do see the time, Julie, so I will shorten up on my closing comments. I just was taking you back to, this is a photo On the left would be this gentleman admission photo, and then that would be the same gentleman. And it's not really capturing, he had a very flat affect when he was admitted. But you'll see him on the right at our recent anniversary party here, and he was so engaged. So his story was, he had been a safety concern at home. He had wandered out of his home and community, saw him go to the hospital, and he was placed on 2.5 milligrams of Risperdal twice a day, and months passed, and then this little gentleman was being admitted to us. So usually it would be a month after. We usually let the resident come in, get settled with us, develop those relationships, and then we start deprescribing. But he had no signs or symptoms of anything warranting that medication. His only diagnosis was that of dementia. So our doctors were very supportive of, and we started that slow titration. So he was admitted on April the 29th, and by the July, I believe the 26th or 7th, we had taken a 0.25 of risperidone at each titration downward. So within the period of 3 months, he is totally weaned off that medication, and he is just a positive story for him. There was a continued overall improvement in the resident, and he is more engaged in life. His ability to train, he came in unable to walk and hardly able to transfer, but we got that adjusted, but now he is back on the walking program. His appetite has improved, and at the anniversary party, he had a wonderful time. And as he's humming along with the tunes of the band, he said, one of those band members is from up my way, and that's such a rural Rexton. Everything in Rexton, we talk about upriver, and that's a span of an area that extends like about a 50-kilometer radius around us. So that's our story. That's this us in a nutshell, so to speak. And we'll happily go back to Julie. Thanks, everyone.
Thanks so much to Sharon and Juanita and the fantastic work that's happening at Rexton Lions. You know, I wanted them to come and talk to you today for a couple of reasons. So, you know, they are a smaller home, they are a rural home, and they made it work. The other thing, Juanita did such a fantastic job of explaining, you know, sometimes not one approach works for everyone. Sometimes you have to try different approaches, and Juanita stuck with it. She was a champion, and she continues to be a champion of appropriate use of antipsychotics, and she didn't want to have to start antipsychotics with that woman. So she was able to be persistent and try different things. So fantastic work at Rexton Lions. Your numbers and your results reflect that in the CIHI data, and congratulations to Sharon and Juanita and your entire team for the ongoing work that I know will continue. And you did just perfect. You did just fine. So we'll go to the next slide, please. So next steps, you can review the long-term success tool with all of your teams and go through the tool as appropriate. Again, if you have any questions about that, reach back to your coach and or HEC, but also think about next steps. So part of sustainability is, you know, considering what else when you get through your cohort or your building or your organization, what else could you be looking at? So think about spread and scale of successful practices of deprescribing that can be applied to other drugs. So consider your benzos, your hypnotics, your sedatives, and your antidepressants, and understand where the opportunity lies now that you've built capacity and supported that capacity within your team. Next slide, please. So I think that's it for me. I'm going to turn it back to Nicole. Thanks, everyone.
Thanks so much, Julie, for your presentation and going through the long-term sustainability tool, and to Sharon and Juanita for sharing the beautiful story and so many comments in the chat box about how inspiring this is and the time you put into improving the quality of life and such a person-centered care approach. So maybe I could get you all to come back on camera and unmute yourself, Sharon and Julie as well. And there's just a couple quick questions in the chat, just confirming about everyone loved this hug by laugh, not a doll, but a hug device. And yeah, so I don't know if it was someone on your
Yeah.
team or someone else had said, and I found a link to this Eugeria company online. So if confirming that's where you guys sourced yours as well.
Sorry, what?
That's
Did-
where you got it from, Juanita?
It is on Amazon.
It
On
is
Amazon,
on
eh?
Amazon.
Mhm.
Okay, that's great. And sorry, I wasn't supposed to turn it back to Nicole. So
Oh,
I was supposed to do the questions. So Cynthia has put some comments in the questions. Shows you need to move. Is sorry. And so it shows that the
Yeah.
need to move is the need to soothe. All right, that was a tongue twister. You got me, Cynthia.
Beautiful quote, though. Yeah, it's a good way to remember it, eh?
Absolutely. Lots of comments about this is a wonderful and adaptive alternative. Thank you for sharing. Asking again where you got the hug, and you got it on Amazon. Sarah
Hug
asked,
by Laugh.
yes, hug by lap. Sarah asks what the medication history. So again, Juanita took all of these steps so as not to have to go there with antipsychotics, but Sharon gave a great example of a gentleman who came in on risperidol and they were able to get him off. Cynthia says, I so enjoyed, oh, there she is.
Who wouldn't want a hug?
I
Great.
love that lady.
Shared experience here in Rexton.
Yeah, absolutely. And just lots of congratulations on the impacts of the stories. So fantastic work. Thank you for sharing, ladies.
Yes, thanks again. So maybe FA will pull up the slides again before we let everyone go, just to give a reminder about the next award opportunity. Thanks so much. So once again, registration for the Sparking Change in AUA Awards program is still open, but only until October 1st. So long-term care homes in Canada can register through the link on your screen, and the program offers support and opportunities to win monetary awards. So if you register, then you'd be able to submit for this next award, the Workforce Safety Award, which closes October 17th, and your home could win $5,000 in a random draw for sharing this photo essay. Next slide. Just wanted to say a huge thank you to everyone for joining us today, and thanks again to our speakers as well as our many webinar producers. Please don't hesitate to contact us at the email here. And you should see a poll popping up. If you don't mind taking just a moment before you go to fill in this final poll. The questions are whether this webinar provided useful information, whether you intend to share what you learned with others. I know more about this topic than I did before participating in this webinar. And lastly, a question about gender, which is of course optional, but something that we collect on behalf of our funder, Health Canada. So we'll leave that up. Thanks again, everyone, for joining us. What a wonderful presentation webinar we had. Great success story. So this concludes today's webinar. And have a great day.